Good morning, everybody. Dr. Ashwin Sridharan graduated with a Bachelor of Science in Biology from Cornell University in 2006. He received his MD from Tufts University School of Medicine in 2010. He completed his residency in internal medicine and fellowship in hematology and medical oncology at Albert Einstein's Montefiore Medical Center. He completed an additional year of lab research training under Dr. Amit Verma, studying clonal hematopoiesis and genetic changes associated with myelodysplastic syndromes and treatment-related acute myeloid leukemia. He has been an assistant professor of medicine at Rutgers Robert Wood Johnson Medical School in the Division of Hematology since July of 2017. Where he serves as a key clinical faculty for the Hematology Oncology Fellowship Program. And he's also a member of the Hospital QI Committee, which derived from his interest in improving the quality of care of sickle cell patients in the hospital. He specializes primarily in non-malignant hematology and also attends on the inpatient leukemia service. Dr. Sridharan's talk this morning focuses on therapeutics in the adult sickle cell patient. The health and survival of children with sickle cell disease has improved considerably over the past several decades, leading to a growing population of adults with sickle cell disease. Nevertheless, adults with sickle cell disease continue to face high multi-system morbidity and a shortened lifespan, with their mean lifespan only still around the 4th and 5th decades. There's an urgent unmet need to improve therapeutics for this patient population. It's my pleasure to introduce Dr. Sridharan, who will discuss moving forward new and emerging treatments for sickle cell anemia. Dr. Sridharan.
Thank you, Dr. Phillip, for that introduction. And thank you for the invitation to speak today on sickle cell anemia. And like Dr. Phillip said, I hope that after today's talk, we can know a little bit more about what's new in the treatment of this disease and kind of what's on the horizon. So I have no relevant disclosures. The history of sickle cell disease, this is a disease that's long been known about. In many African tribal languages, there are actually words and phrases to describe some of the symptoms that patients with sickle cell anemia experience. This disease was first reported in 1910. That was the first reported case report of this disease, where a Black dental student was experiencing pain episodes and was noted to have anemia. And when his blood smear was examined, he was noted to have the pathognomonic sickle cells they were seen. In 1927, Han Gillespie started to explain the pathophysiology of the disease by noting that sickling can be induced in low oxygen conditions. The genetics of the disease were established in 1949, and in 1951, Linus Pauling and Itano, they discovered that abnormal hemoglobin structure in patients with sickle cell disease was seen, and this led to the phrase of the first molecular disease. That's the first time we've had a quote unquote molecular disease, and it was sickle cell anemia. That was the first molecular disease. To quickly review this is just a diagram of what hemoglobin looks like. We have 2 beta subunits and 2 alpha subunits. And when talking about sickle cell anemia, it's important to know where the disease is, what genes are affected, and that actually can have a lot, it can explain a lot about the symptoms that a patient experiences and why some patients are sicker than others. So the pathophysiology of the disease, sickle cell anemia is a disease of the beta globin chain. It results in a hemoglobin called hemoglobin S. And the hemoglobin S gene mutation, it arose spontaneously in multiple geographic areas within Africa. There are a few different haplotypes. They're called the Cameroon, Senegal, Benin, Bantu, and Saudi Asian varieties. there's a single nucleotide mutation, and a single adenosine is changed to thymine, and that results in valine being substituted for glutamic acid. And what this does is, under low oxygen concentration, hemoglobin S will polymerize and precipitate, causes the vaso-occlusion, which is what defines the disease. So there's obstructed flow through the small capillary beds, and that's what causes a lot of the morbidity associated with this condition. For carriers of the disease, it's thought to confer a survival advantage for people with for malaria. And the reason for this is that because malaria parasitizes red cells, and in carriers, this red cell will rupture prematurely before the parasite has had a chance to complete its life cycle. So it leads to ineffective reproduction of the of malaria in infected patients. So this is a 1 second. I'm sorry.
Ashwin?
Yep.
We can't see your slides. I don't know if you have slides you're sharing.
Oh, I'm sorry. Maybe I haven't shared my screen. Hang on 1 second.
That's okay.
Apologize. Can you guys see them now?
No, still can't see them.
Oh.
There we go.
Got them? Okay, thanks. Sorry about that.
That's okay. If you want to go ahead and start the PowerPoint presentation.
Yeah, no problem. Okay. Let me just make sure. 1 second, I just want to make sure I can see my comments. Okay. So this is I've moved on a few slides. I'll just pick up from where we were. Okay. So in terms of the, in terms of the, this is just basically a slide about the pathophysiology. And this slide sort of explains where the, these are where the different haplotypes of the, of sickle cell anemia arose. So it arose in 5 different areas, and just because one haplotype is the one that's affected, it's not geographically restricted to any of these areas. So this is a representative blood smear for a patient with sickle cell anemia. If you can see the characteristic sickle cells here, these long lance-shaped cells, kind of in these types of cells here, these are the ones that these are what cause the disease and the problems. So this is a slide that it depicts, some of the, there are different types of genetics of the disease, and it's sort of important to understand what the differences are, to kind of understand which patients have severe disease, which ones have milder disease, what are the findings that you may note. So SS is one of the severe forms. That's the first one described in the top. So in that one, you have patients will have low hemoglobin levels. The hemoglobin S is the predominant in 80 to 98% of the hemoglobin noted on a hemoglobin electrophoresis. Variable amounts of hemoglobin F. SC disease is one where you have a hemoglobin S on one side, hemoglobin C is the other beta globin mutation, and it usually is a milder form of the disease, but can be associated with with painful crises. In patients with S trait, it's not a 50-50 split of sickle hemoglobin S and hemoglobin A. Usually the hemoglobin S has a shorter half-life and decreased survival. So it usually amounts to about 35 to 40%, and hemoglobin A forms the predominant amount. There are 2 types of beta thalassemia that can be associated with sickle cell disease. So there's beta 0 thalassemia, which is about 80 to 90% hemoglobin S. That's functionally behaves very similarly to hemoglobin SS. There's almost no normal beta chain synthesis, and all that is produced is hemoglobin S. It's a very severe form, behaves very similar to hemoglobin SS. And there's S beta plus thalassemia, where there is a variable amount of hemoglobin A that is produced, is usually a milder form, but patients can still experience frequent pain crises. In terms of the chronic health conditions, some of this was on, Dr. Phillip mentioned a little bit about this. Despite improvements in the care of younger patients, for various reasons, the care of older patients is not as good. Plus, the disease is also pretty aggressive and can lead to the onset of end organ dysfunction much earlier than other patients. So in patients with SS disease, this was an older study. This was published during the 90s, but it suggested that the lifespan for male patients was only about 42 years, and in females was about 48 years. It is longer in patients with hemoglobin SC disease. There are frequent causes of death in older patients. It's usually organ failure. So we think about patients having, there's a much higher incidence of renal failure. There's higher incidence of congestive heart failure, pulmonary hypertension, cardiac dysfunction, as well as there's also an increased risk of sudden death. And you know, in this study, there was difficulty abstracting the cause of death, but you know, the lifespan of patients with sickle cell disease who are older is significantly less than healthy cohorts. And this slide was just, I basically included this slide just to talk about many of the different organ systems that are affected by sickle cell anemia. So in terms of cardiopulmonary disease, the patients do develop pulmonary hypertension, restrictive lung diseases, left ventricular dysfunction. Patients are at higher risk for sudden death. In terms of the nervous system, the patients are at much higher risk of stroke. There's neurological dysfunction, chronic pain. There's also cognitive impairment due to silent infarcts that are especially common in children. In terms of the hematological system, there's also abnormalities in immune function, and patients are significantly at higher risk for infections, especially as children. And in terms of the urogenital system, I'll highlight the main issue is renal dysfunction, especially as patients get older. One thing that's not talked about a lot in sickle cell patients that is talked about, it seems like it's talked about more in patients with other types of diseases that require exposure to chronic transfusions. There was also back in the 1980s, before the blood supply was declared free of HIV and AIDS, there were a lot of transfusion-associated cases of HIV. Although there does seem to be some data that says that in patients with sickle cell anemia, there's less HIV associated with transfusions than in other patients who are exposed to chronic transfusions due to congenital causes. It's important before we move on to talk about other issues, is that there is we do have to differentiate between chronic versus acute pain in patients with sickle cell anemia. So most of these studies that we're going to be talking about, and a lot of their outcomes, are actually outcomes in terms of acute pain. And acute pain is what we typically call, and what we usually take care of patients for, is what we call a vaso-occlusive crisis. So this is where patients are feeling their normal selves, and then all of a sudden they have an acute onset of pain, which is very, very severe, forces them to, you know, seek medical care, requires pain medication administration, fluids, those types of things. But many patients with sickle cell anemia also suffer from chronic pain. You know, and the treatment of those conditions is very nebulous, poorly understood, and there's a lot a lot of work needs to be done in the treatment of that. But we are starting to understand a little bit more of the pathophysiologic the pathophysiologic causes of that chronic pain. There's thought to be central and peripheral neurological dysfunction in these patients. And patients with sickle cell anemia have different thresholds to experiencing pain than patients without sickle cell anemia. So these things, we're not going to be talking too much about the chronic pain associated with sickle cell anemia. We're talking more about vaso-occlusive crises today, but this is a large area and a large need that isn't really being met very well right now, but is an area of active research. So the first medication we're going to talk about, this is not new, this is old, but this is HYDROXYUREA, and this is the mainstay of treatment for patients with sickle cell anemia, and has been for quite some time. So it's an older medication, and it's been in use for the treatment of hematologic malignancies since the 1860s. The mechanism of action is unclear, but what we do know is it leads to increases in hemoglobin F, which are stable. And this actually, what we do know it does is that it inhibits ribonucleotide reductase, which is important in the conversion of RNA, or is important in the production of DNA building blocks. So during times of stress, what seems to happen is it may force more of a conversion from the hemoglobin beta subunit synthesis or sickle subunit synthesis in patients to a gamma subunit, which is what changes patients' hemoglobin, predominant hemoglobin, from hemoglobin A to hemoglobin F. And what it also does is, as it is a myelosuppressive medication, it reduces neutrophilia and reticulocytosis, which inhibit the flow of blood through the microvascular system. And therefore, in two different ways, it can actually improve the symptoms of sickle cell anemia. So just to review this slide, this is a, probably some people may not have seen it since med school, but this is just a, it's important to know that these are the changes in the synthesis of alpha and beta hemoglobin subunits. Adult hemoglobin A is made up of alpha and beta chains. Hemoglobin F is when we substitute the beta chain for a gamma chain, and that process usually stops, or beta becomes the predominant form of hemoglobin a few months after birth. And once that happens, hemoglobin A becomes the predominant type of hemoglobin in the blood, and hemoglobin F is usually is still in the blood at low levels. So what hydroxyurea does is it, hemoglobin gamma, or the gamma subunit, is still functional in patients with sickle cell anemia. So if you can switch them from hemoglobin A into hemoglobin F, you can improve the circulation, the microvasculature, improve a lot of the chronic medical problems that these patients experience. So, this medication had been used a little bit in the 90s, but not, it was a large multi-center trial in the mid-90s that actually got this medication to the forefront. So there was a randomized double-blind placebo-controlled multi-center study that enrolled adults who had experienced 3 or more crises per year. So they were randomized to receive 15 mg per kg of hydroxyurea versus placebo. And the primary outcome was painful crises, requiring a visit to a medical facility lasting more than 4 hours, requiring parenteral narcotics. Different studies use different, slightly different definitions of a pain crisis, but this is a pretty appropriate one. And after 21 months, the study was stopped due to the inferiority of the placebo group. So this is a study that this is a graph that basically shows that not only was CRISES, it's a long-term follow-up study, but what this graph shows is that patients who were actually exposed to Hydrea actually had a longer survival than patients who had never been exposed to Hydrea. So not only is Hydrea not just changing or impacting pain crises, it also seems to have an impact on mortality. There isn't a long-term, totally randomized study that shows this, but this was a long-term follow-up from that initial study that seemed to suggest that this was the case. And in this trial, this is just another portion of that trial, which showed that there were a few different markers that were affected. So A shows that the event rate of crises was significantly lower in the hydroxyurea group. Also, things that were noted is that the MCV of the patients increased, the reticulocyte count decreased, the percentage of what we call hemoglobin F cells, these are erythrocytes that express hemoglobin F, increased, and the cumulative event rate also dropped as well. So on the basis of this, hydroxyurea was actually, there were expansions of it to try it in children and infants as well. So this is a trial called the Baby Hug trial that was actually done in the 2000s, and they started to enroll patients between the ages of 9 and 18 months of age to try to see if early intervention with Hydrea would, the primary endpoint in the trial was trying to make sure to see what to decrease the size of the spleen. However, they were also looking at a number of other outcomes which were important, including like pain crises, hematologic parameters, etc. So the primary endpoint of spleen enlargement was not seen, but there were significant improvements in the secondary outcomes, some of which are documented here. So the hemoglobin level in these patients increased, the MCV increased, the number of platelets decreased, the leukocytosis decreased, and these are just hematologic parameters. But on the next slide, we have a look at the some of the clinical outcomes that are important, including acute chest syndrome, pain crises, dactylitis, and transfusion requirements. And all of these decreased in the patients that were treated with hydroxyurea. So on the basis of this trial, also this trial was looking at safety. Hydroxyurea was noted to be very safe. So on the basis of this trial, hydroxyurea's use was also expanded to very young children. In terms of, so hydroxyurea, based on this and other trials, it's been an essential medicine in the WHO for some time. Mainly for the treatment of chronic myeloid leukemia, but there's also emerging data that it can be used safely, not just in the United States where here we do it with frequent blood transfusions, or I'm sorry, with blood monitoring, but it's also noted to be an essential medication. And it can be used in sub-Saharan Africa. So this was a paper that was published in the New England Journal in 2019. It was basically a pilot study to see if this could be safely done in Africa and sub-Saharan regions, resource poor areas. It was also a plenary at the American Society of Hematology in 2018. And what they found was that they were able to safely do this and improved the lives of children in sub-Saharan Africa. So there are some clinical considerations and limitations we should discuss. So one is that this is not a medication that's going to work acutely. It's not going to help patients with their pain immediately. It's going to take weeks to months to work, because this is a medication that is working in the differentiation of red blood cells. It's causing a switch in the production of different types of hemoglobin. So this is something that's going to take a long time to work. So while we can discuss it with patients inpatient, if they're not on it inpatient, it's not going to help during a acute vaso-occlusive crisis. In terms of giving it to patients, it requires compliance. There are GI side effects are the main things that we hear from our patients when we give it to them. Either nausea or lack of appetite, things like that. Myelosuppression, so basically the other blood counts can be decreased by this medication. There is an increased risk of skin cancer, actually, and, not really melanomas, but basal cell and squamous cell cancer for patients long term. There was a prior concern when this medication had been used. This is a medication that's used for a lot of different hematologic malignancies as well. There was a concern regarding a risk for secondary leukemias. That risk is actually not substantiated in subsequent studies. This concern came about mainly when it was being used to treat myeloproliferative neoplasms, such as essential thrombocytosis and polycythemia vera. These are conditions that have an inborn risk of conversion to acute myeloid leukemia. And in 3 of the patients that were treated with this in older studies, secondary AML did develop. So on that basis, for quite some time, hydroxyurea carried this concern that there was an increased risk of secondary leukemias. That hasn't been borne out in any of the sickle cell trials, though. Sorry, 1 second. Oh, I'm sorry, I'm going back to the beginning. Okay, sorry. So now I think we're gonna talk a little bit more about some of the newer therapies that are coming out for the treatment of sickle cell anemia. So one of these is actually L-glutamine. So L-glutamine has a very interesting pathophysiologic reason for why it may be helpful, and this is basically a slide that outlines that reason. So cells take up L-glutamine, and it actually leads to an improvement in it actually leads to an improvement or generation of compounds that can reduce oxidative stress. So these are things like glutathione, and based on basic science data, there was actually evidence to suggest that sickle cell patients have a function, or sickle cells have a functional decrease in the ratio of glutathione to the pre-reduced thing, and that was what was suggested, that if patients can be supplemented with L-glutamine, it may lead to an improvement in their disease and an improvement in pain crises, etc. So based on this, L-glutamine was was trialed in a phase 3 multicenter placebo-controlled double-blind trial. They enrolled patients, and this is where where what we talked about in terms of definitions of sickle cell disease. This is where this is important. So we have to look at in each trial which patients were enrolled. So they enrolled patients with what I would call severe sickle cell. These are patients who had hemoglobin SS or hemoglobin S beta 0 thalassemia, who had at least 2 pain crises in the prior year. And they enrolled them in a 2-to-1 ratio to receive what they call pharmaceutical grade L-glutamine versus placebo. So they allowed for concomitant use of prior stable hydroxyurea dosing. So all of these trials that we'll discuss didn't allow patients to begin hydroxyurea while in the trial, but they allowed them to enroll and join the trial while taking hydroxyurea. And the primary endpoint was the number of pain crises through week 48. And there were multiple secondary endpoints for complications due to sickle cell anemia. So in terms of the number of pain crises, there was a modest decrease a very modest decrease in the number of crises annualized. So the mean was about 3.2 and in the L-glutamine group, and it was 3.9 in the placebo group. Median was about 3 versus 4. There was also a significant reduction in the mean number of hospitalizations for sickle cell related pain and the median number as well. You know, in terms of the episodes of acute chest syndrome, there did seem to be a slight decrease in the numbers as well. So the main takeaway from this is that it did slightly decrease the number of pain crises per year. So there was a modest decrease in the reduction of pain crises. And one of the limitations of this trial was that a large number of patients did actually withdraw from participation. And this is going to be a common theme in a lot of the medications and the treatments that we discuss. But there was actually, this is a very, very expensive medication. This is a medication, they call it pharmaceutical grade L-glutamine. So this is what's approved for use. So that is patented and costs quite a bit of money, about $40,000 per year. The next medication we'll talk about is VOXELOTOR. So this is a potent allosteric effector of hemoglobin S that has a high affinity for hemoglobin. This allows hemoglobin S to maintain an oxyhemoglobin state under hypoxic conditions, and it'll delay the polymerization of hemoglobin S as it passes through the microvasculature. So there is a similar, this delay in deoxygenation it's similar to what is seen in hemoglobin F. So it's proposed that this would lead to decreased sickling, both, and it was noted to decrease sickling in vitro and in vivo preclinical models. And it does also in mouse models, it was found to improve hemolytic perimeters, it decreased reticulocytosis, and increased hemoglobin in these mouse models of sickle cell disease. So this is not an oxygen dissociation curve, but this is optical density as measured over time in different types of hemoglobins. On the right you see what the curves look like for a percentage of VOXELOTOR, which is the medication, and on the right side you see what it looks like for variable concentrations of hemoglobin F. And you see a similar effect that as the optical density increases, that's time to sickling, meaning that the cells are starting to clump together and it affects the optical density in the study. And as you see that as there's an increasing percentage of hemoglobin S bound to VOXELOTOR, it leads to delayed sickling. And it's a similar kind of distribution for both VOXELOTOR and for various proportions of hemoglobin F. So on the basis of this, the HOPE trial was started. This is NCT 030368813. This is a phase 3 double-blind placebo-controlled trial for patients with sickle cell anemia, and they were randomized 1:1:1 for either high-dose VOXELOTOR, medium-dose VOXELOTOR, or placebo. Patients who were enrolled had about 1 to 10 pain crises in the prior year. And the primary endpoint, the primary endpoint for this was not crises or reduction in crises. It was looking for an increase in hemoglobin. And that was defined as 1 gram at week 24 of treatment. The secondary endpoints were were changes in hemoglobin from baseline and lab markers of hemolysis and annualized incidence rate of pain crises. So chart A is a waterfall plot showing the increases of hemoglobin in the three groups, and 59% had a response in the VOXELOTOR, the high dose arm, compared with 38% in the medium dose arm and 9% in the placebo arm. And graph B showed that these results were pretty sustained. I mean, like, or it works pretty quickly is what that's really showing. You know, usually within the first few weeks of the medication, you see an increase in hemoglobin, which usually persists. This is another trial that, or another slide that basically shows that not just was there a difference noted in the hemoglobin, but the markers of hemolysis improved as well. So here we're looking at changes in the indirect bilirubin level, percentage of reticulocytes, and the absolute reticulocytosis as well. So what was noted though, and this is kind of what one of the big takeaways of the study was. So this trial did not actually show a statistically significant reduction in pain crisis. So what this, the numbers were a little bit lower, but they did not meet the cutoff for statistical significance in any of the treatment arms. So while this medication does raise hemoglobin levels, it did not actually reduce the number of pain crises. Another issue that was reported in this, there was no quality of life survey performed. So, you know, we did mention kind of earlier how there was a chronic component to sickle cell pain, and there's also an acute component to sickle cell pain. So if you're giving this medication to a patient, the patient may not even notice day to day any real change in their pain, because, you know, we don't really even know what the quality of life surveys for this was. So in terms of where would we use it, and we've talked to some of our pediatric colleagues on and how they're using it. It's a reasonable option for patients who suffer from severe anemia, or patients who are on transfusion protocols for various reasons, either for prior history of stroke, or TIAs, or silent infarcts, who need to maintain a hemoglobin level of 10, which is the evidence-based number of where they need to be. So it's a reasonable option for those patients to reduce transfusion burden, things like that. But it's to promise patients that they're going to have improved pain control with this medication. The evidence and the statistics don't really back that up. And again, kind of back to what we had talked about, this is a very, very expensive medication, costs $84,000 per year. So this next medication is CRIZANLIZUMAB. This is a IV monoclonal antibody that's also being used, that's also now approved for the treatment of sickle cell disease. So it's a humanized monoclonal antibody, and it binds to P-selectin, and it blocks the interaction with P-selectin glycoprotein ligand. So P-selectin is one of the early initiators in the microvasculature of adhesion of leukocytes to the endothelium. So transgenic mice in a sickle cell model that are deficient in P-selectin and E-selectin show reduced vasoocclusion. And this suggests that P-selectin blockade can reduce vasoocclusion, inflammation, and pain crises in patients with sickle cell anemia. So on the basis of this, the SUSTAIN trial was started. This is a disease, and again, definitions are important. So this was a disease that looked at almost any patient with sickle cell anemia, hemoglobin SS, hemoglobin SC, S-beta 0 thal, and S-beta plus thalassemia, patients who had 2 to 10 pain crises per year. So this is different in that it's targeting almost all sickle cell patients who have frequent pain attacks. Again, similarly, patients were allowed to be on hydroxyurea, but they were not allowed to start while they were on the trial, and patients with chronic transfusions were excluded. They randomly assigned patients 1-to-1 to either receive low dose, high dose, or placebo, and the primary endpoint was annualized rate of pain crises. Secondary endpoints included annual rate of hospitalized days, time to first and second crisis, annual rate of uncomplicated crisis, and annual rate of acute chest syndrome. And in this study, they actually did provide a pain questionnaire that was sort of looking to assess quality of life. So in terms of the results, they enrolled 198 patients at 60 sites, and there was a statistically significant decrease in the number of pain crises per year. It was 1.63 in the high dose treatment group versus 2.98 in the placebo group. There was a non-statistically significant decrease in the low dose group versus placebo, and a significant number of patients in the high dose group, 36%, did not experience any pain crises during the follow-up period versus only 17% of patients in the placebo group. And not only was, and one of these are some of the secondary endpoints, time to first sickle cell related pain crisis, that was significantly delayed in the high dose group, as well as time to second crisis. That was also significantly delayed in the high dose group. So in terms of how to use this medication, one thing that was very beneficial about this study was that it looked at patients with almost all genotypes of sickle cell disease, any patient that experiences frequent pain. So it could be potentially beneficial to any of these patients. You can use this medication with or without hydroxyurea. The benefit in terms of reduction in pain crisis was also noted, not just in subgroup analysis of patients who were already on hydroxyurea. This benefit was also noted in patients who were being treated with hydroxyurea. This is compared to the previous medication, VOXELOTOR. This would be a good agent of choice for patients, not necessarily based on just treatment of the anemia itself, but for patients for whom pain is a major consideration, for whom pain is a major part of their disease. But again, there is a significant annual cost to this medication as well. So we're going to now pivot from medications that are now approved and talk about kind of what's coming down the pike. And we'll probably just use the remaining time to talk about gene therapy, which is a very exciting and emerging treatment for patients with sickle cell anemia. Before we can get to that, though, it is useful to talk about allogeneic bone marrow transplantation, because this is where the gene therapy may be affecting things or changing things. So allogeneic bone marrow transplant, this is like the only curative therapy that we have to offer patients with sickle cell disease. There are panels of experts. Expert recommendations actually recommend, if HLA matched identical siblings are available, that this transplant be considered as early as possible, even for like preschool age children, as early as that. The evidence, though, for transplant in adults is a little bit more murky. There are studies, and it's been looked at in adults. However, the outcomes are not as good as in young children. In large cohorts there was a large cohort study published in 2017 of 1,000 patients who had been transplanted in Europe, and while they did find that there was a good long-term results, they did note that 7% died, mainly due to infections. 2.6% of patients experienced graft failure as well. And the event-free survival, or I'm sorry, I wrote increased, but the EFS, the combination of death versus graft failure, that decreased with age. I wrote increased here, but it actually decreased with age. This next slide shows two things. The incidence of GVHD by age in the top panel, and the incidence of GVHD was higher in adults than in children in this study. And in the bottom, it shows the incidence of, the overall survival in patients. The green arrow in the top being cord blood transplants. The vast majority of patients, the bone marrow, the CD34s were obtained from bone marrow sources, and peripheral blood is the least favorable one to be used. Peripheral blood can be associated with higher rates of GVHD, so it's generally not what you want for patients with who are undergoing transplant. There are limitations, though, to this, mainly the first one being that there are poorer outcomes observed in adults. Adults tend to have increased rates of end organ dysfunction, which can make getting through an allogeneic bone marrow transplant much more difficult. In children as well, the availability of matched siblings is a challenge. Having that for every patient is not, not every patient is going to have that. And the rate of graft versus host disease is another problem as well, because these are allogeneic sources. So now after that, we're going to kind of pivot and talk more about gene therapy. So this has basically been the pipe dream of like almost anyone who works with patients who have a molecular disease. You know, can we change a patient's DNA to actually eliminate the disease? And while this has been around for a long time, it's heated up significantly lately. So, you know, there are two kind of ways to think about how can we do this for patients with sickle cell anemia. How can we change their DNA to eliminate or reduce the burden of disease that they have? So one way of doing this is to correct the beta subunit defect. So instead of patients making hemoglobin S now, can we get them to now make hemoglobin A? Or can we silence beta subunit synthesis, sort of do like a genetic HYDROXYUREA effect, and then therefore induce gamma subunit production, and then shift from hemoglobin S to hemoglobin F. How do we make the genetic change? This has been one of the, you know, we know the genetics, we understand the genetics, but this has been one of the holdups that has kind of prevented us from getting this done. So viral vectors that can carry the gene of interest into the cell and make the change. That's what had been kind of the primary way in which this has been done. And non-viral vectors as well, you know, naked DNA, gene guns, electroporation. And also what's, since this is a disease of beta subunit production, whatever you kind of think about will work for hemoglobin or for sickle cell patients can also help patients who suffer from beta thalassemia. So often a lot of the products and things that are being developed and thought about, they're not just being trialed in patients with sickle cell disease, but also in patients with beta thalassemia. So this is kind of one way to, you know, these are the two ways in which this can be done. So either with a lentiviral vector, you can correct it directly. You can knock, that's what 1A suggests. 1B suggests that you can knock down a specific promoter of beta globin synthesis. And 1C is forced locus control region. If you can loop it, the control region, to the gamma subunit, you can specifically induce the production of the gamma subunit. Genome editing with CRISPR is what's really been one of the big changes lately, and we're going to talk a little bit more about that as well. You can correct the gene itself through CRISPR. You can use CRISPR to knock down the promoter, or what you can do is use CRISPR to, you know, we are learning more about there are patients who have persistently high hemoglobin F levels. So we are understanding those genetics better. Can you induce mutations using CRISPR to increase the production of hemoglobin F? So these are the methods in which this is being thought about. So I kind of had to go back and think about CRISPR and kind of understand CRISPR a little bit better and kind of understand how this works. But, you know, CRISPR stands for, you know, there are palindromic repeats that are noted that are regularly interspaced in the genome of bacteria. And this was first noted in kind of independently by a number of different labs. And in between these repeats are what we call spacer regions. So bacteria actually acquired this ability or acquired these changes as a way to resist viral infection and to resist death. So a bacteria basically gets infected by a virus, remembers a piece of the DNA if it survives, and incorporates it into its own genome. And then it produces a Cas9 nuclease, which basically takes a RNA, a guide RNA, and then it can actually trace back. If it ever sees that virus again, it'll find it, and then this enzyme Cas9 will then cut the viral DNA. And what we can use this is we can use this as a very specific gene editing tool, where we can now target specific parts of the human genome using this to find a spot and then use a piece of DNA as a template for repair to change the genetics that you in human cells. So based on this is kind of from the beginning to the understanding of how we know that BC11A is a enhancer region of beta globin synthesis, and this is how this was started basically understood. So based on whole genome sequencing, especially there's a set of patients in Sardinia that actually have high persistence of hemoglobin F, and genome-wide sequencing actually isolated the BC11A locus. as one of the, there are a few different sites, but that is one of the sites of interest, that patients with mutations there were noted to have high hemoglobin F levels. This was basically validated, and it's been since understood that if you can knock down this locus, if you can affect this locus, it will lead to higher productions of hemoglobin F. So on the basis of this, a product was developed that would potentially help patients with sickle cell anemia and also with beta thalassemia. So this is this study was presented in the New England, or was published in the New England Journal in 2011. They report on one of the patients, but there's actually two patients that have been reported on. We'll talk about the second patient in a second. But this was a report of two patients, one patient with transfusion-dependent thalassemia and one patient with sickle cell anemia. They were enrolled in two separate trials that are treating both sets of patients. So patients were, sickle cell patients are allowed to enroll in this trial if they have 2 or more severe vaso-occlusive crises per year over the past 2 years. And CD34 hematopoietic stem cell precursors were collected using apheresis after mobilization. And CTX001, this is the edited gene product. This was manufactured using CRISPR-Cas9 gene editing, and the gene of interest was introduced with electroporation. And following myeloablative chemotherapy with busulfan, this product was then reinfused into patients. So this is basically, fortunately we've seen panel A before. This is our, the changes in hemoglobin type over time, the shift from hemoglobin A to hemoglobin F, just sort of, re-emphasizing that hemoglobin F is what we're interested in here. And B shows the CRISPR-Cas9 targeting and how it targets a specific enhancer, the erythroid enhancer region in BC11A. This region is what actually binds to GATA1, which is a master erythroid transcription factor. So if you edit this and change this site, maybe that we can now make hemoglobin F. And panel C shows in the preclinical data before this was given to patients, in CD34 cells collected from healthy volunteers in edited versus unedited, there was a significant increase in the fraction of hemoglobin F. So this is work that had been done prior to using this vector on patients. So this is one patient that had been enrolled. The patient that was enrolled was a 33-year-old woman who'd experienced multiple frequent pain crises, had multiple complications of her sickle cell anemia, including history of cholecystitis, cholelithiasis as well, gallstones. So what basically happens in these patients is they have a run-in period, or if you notice in panel D, and I'm sorry it says DEF because ABC was the thalassemia patient. But in panel D, you see the different colors. You see hemoglobin F is blue, hemoglobin S, which is sickle cell hemoglobin, is purple, hemoglobin A is green. That's quote unquote normal adult hemoglobin. And you may notice, this is the prior amount. So this is a patient that had been receiving transfusions prior. So you do see some amount of hemoglobin A prior, mostly sickle cell hemoglobin, and a very small amount of hemoglobin F. The patient then receives, per protocol, an exchange transfusion just prior to infusion of the product, which is why you see there's a replacement almost entirely of hemoglobin A, right, at 1 month prior. Sorry, 1 month post-infusion. And then over time, what you see is a stable, slow but stable increase in the fraction of hemoglobin F, 25%, 37%, 46%, basically settles into the 40s. The goal of treatment with hydroxyurea, where we say, okay, this was a success, we've increased hemoglobin F, this should improve the patient's symptoms, is actually just to improve the hemoglobin F level above 20%. So to increase it into the 40s is great. And when you see the number, the hemoglobin level afterwards, the patient started with the hemoglobin level in the 7s, and it actually increased to the 11s and 12s afterwards. Panel E shows the fraction of hemoglobin F cells. Remember, hemoglobin F cells are cells that express some amount of hemoglobin F. The number of hemoglobin F cells present can correlate with disease activity, and almost all cells express some portion of hemoglobin F. And panel F, what that shows is that shows the frequency of crisis running in and the frequency of transfusions running in and running afterwards. And there's a small little box that's blown up right following the infusion of the product. And there were some transfusions there, but since the time of infusion, the patient experienced a few days after the infusion, like about a month after the infusion, there were no more transfusions needed, and there were no more pain crises reported. This was actually presented at the American Society of Hematology just prior to the publication of this paper. They reported on a second patient who was also treated on this protocol. The prior patient had a much longer follow-up, so this patient has a shorter follow-up, but you're seeing a similar pattern. By month 3, there's about 40%, over 40% hemoglobin F, and the hemoglobin is rising. In terms of the safety of gene therapy, there were a lot of adverse events that were noted, but the safety profile is thought to be similar to patients who undergo autologous stem cell transplant for various hematologic conditions. Which is more about the chemotherapy that the patient received just prior to receiving the infusion. So this was based on this was from the ASH abstract, which was done in about 7 patients, 5 with beta thalassemia and 2 who were treated for sickle cell disease. There was also one patient. This was reported. I think we need more information on this. One patient developed HLH, which is a pretty aggressive hematological condition, but the symptoms were reported to have been resolving at the time of the report of the trial. So we just basically described one method in which this is being done, but there are also other methods in which this is being done as well. So and there are multiple companies using a whole bunch of different approaches to doing this, and I just wanted to briefly just to end discuss another one. So this is hemoglobin A, T87Q. So basically, this is a method of repairing the beta subunit production. We had just talked about knockdown of hemoglobin A and inducing hemoglobin F. This is the other method in which we repair the gene. But what they did was they specifically genetically engineered an anti-sickling beta subunit that has one specific molecular difference, so that the researchers can track the increase in this type of hemoglobin over time. So there's a specific amino acid substitution in this variety, and this was a lentiviral-based transduction, similar kind of protocol for everything prior. Collect stem cells from the patient, transduce them, and then reinfuse them to the patient after myeloablative chemotherapy. And this was reported at the European Hematology Association. Sorry for the picture, this is the only one I was able to find. But what this shows is this was tried in several patients, even more patients than the one prior. And there's variable periods of follow-up, but in terms of all of the patients, there was only one crisis. The little triangle or the little diamonds are crises. There was one crisis that was reported in a patient following infusion of the product. So it's likely we're going to start seeing these trials move from these early phases where it's a report of 1 or 2 or 3 patients into the more mainstream, and this is definitely coming down the pike, and it's very exciting because this is basically a way of being able to cure patients of their sickle cell disease, even if they still do produce some sickle cell disease, or some sickle cell hemoglobin. The significant reduction in it is leading to much better outcomes. Awesome. So if there's one thing I've learned about doing grand rounds, you have to end with a cartoon. So I'll just stop here and open it up to questions.
Great. Thanks, Ashwin, so much. If there's any questions or comments, if anybody wants to type it in the chat, or you can unmute yourself to ask. Ashwin, I had a question about, I guess it's the pathophysiology and potential treatment. I know there's been research looking at the activity or the interaction of neutrophils and their involvement in sickle cell anemia and triggering crises. I was wondering if you can just kind of briefly mention that and any potential therapies for interaction with neutrophils.
Yeah, absolutely. So like inflammation is a huge part of the it's a huge part of the disease process. Like anything that basically slows the transit of cells through the capillary system can trigger deoxygenation, can trigger sickling, can trigger crisis. So part of why Hydrea is potentially helpful is it's as a myelosuppressive medication. It will reduce the the neutrophil count. CRIZANLIZUMAB as a medication that slows that affects P-selectin, affects leukocyte rolling and adhesion. So that there is already maybe one medication that affects neutrophils and their role in this. There aren't too many things that I know that are coming that are directly looking at that. And one interesting kind of correlate to what you're saying about neutrophils is filgrastim, which is a normal medication used for mobilization and stem cell collection, dramatically increases the neutrophil count. So we have to actually use plerixafor, which is a completely different mobilizing agent, to collect these stem cells to do the trials. So neutrophils are a very big part of it, but there aren't a lot of therapies directed specifically towards them. But it is very important.
Hi, good morning. I had a question. My name is Cheryl Bordeaux. My daughter is a sickler and she's been placed on Oxberta. She was on the trial phase of that. So now that's been approved by the FDA and she's using that. And it has increased her red blood cells and her everything and her hemoglobin whenever she's been going into any crisis. And they just recently added gabapentin, I guess, to help with the pain. Do you have any thoughts on that?
Yeah, so I mean, gabapentin, so in terms of gabapentin, a lot of sickle cell patients, when they're experiencing crisis, like there's the crisis related pain, and then there's the nerve or neuropathy related pain. So gabapentin is like an area or neuropathic agents that can affect the perception of pain. I think definitely they probably have a role in that. I'm not really aware of like evidence-based trials that show exactly what the effectiveness of gabapentin is in the chronic pain that's associated with this. While the studies didn't show that VOXELOTOR improved overall for the entire trial population, the symptoms of pain crisis, I'm sure there are patients that do experience improvement with it. So, I think it's a good medication to try, but I don't want to, overpromise to patients that it will improve this, because the data on pain crisis is a little bit, it didn't show that it necessarily reduces pain crises. Did I answer your question?
Yes. Do you have any comments on Oxberta, which was a trial?
Yeah.
Now.
Yeah, so it's a good medication. It raises hemoglobin, and there are several sickle cell patients who have severe anemia where their hemoglobin level is much lower, and that is a huge part of their disease. Like if they're experiencing fatigue, or if they need chronic transfusion for issues such as stroke or prophylaxis and things like that. If they've experienced things like that, I think it's a really good medicine to reduce the number of transfusions that patients get. Because transfusions are associated with a lot of potential complications over a lifetime. So I think Oxberta definitely has a role, but I do caution patients that it may not do much for your pain. It may do other things for your disease, but it may not help your pain.
One more question, just on the hydroxyurea. What age do they usually want to start the patients on that? Is there a specific age group or
as early as possible? I think potentially as early as possible. Yeah, it's safe in all groups. There was one of the trials that we discussed earlier, the baby hug trial. So that's a trial that shows that even in infants, like as young as like a year old, it can be given safely to patients. And as a medicine that's been around a long time, things like Oxberta haven't been around for a long time. So if you kind of go on the internet and look for side effects, you may not find it because it hasn't been around a long time. With hydroxyurea, there's a lot of, if you go online and you look things up, and there's a lot of people posting a lot about different side effects that they've heard about or known about. And sometimes when I'm talking to my sickle cell patients about hydroxyurea, there's a little bit of pushback because they've heard or read and seen different things about it. So while there are side effects that we have to talk to every patient about, some of the side effects or that are listed and out there on the internet are not necessarily true. So I do think it's a very good medicine. It's probably the best medicine, but it doesn't work for everybody. And I think that's where we have to look at things like Oxberta, CRIZANLIZUMAB, or Endari, which is the L-GLUTAMINE.
Okay, thank you.
Yeah, no problem.
Okay, wonderful. Dr. Sridharan, that was a wonderful presentation. Thank you very much. We're at the top of the hour right now. And if nobody has any other questions, thank you so much for a wonderful presentation, wonderful grand rounds. And we'll see everybody next week. Remember to enter in your code